Hello, welcome everyone. We have another great session tonight with small bowel lesions, and we'll look forward to getting started here in just a few minutes. Well, welcome everyone to this morning's session. Last time we did a number of gastric entities, and we'll continue on down the bowel and do some small bowel lesions. And this is our first case. As you can see, we have multiple fragments of small bowel. We have a villus pattern here at low magnification. But notice as we look at this, that the color on this tissue is just a little bit more purple, a little bit more reddish blue. There's not a lot of open space here. So that's a clue, even at very low magnification, that there may be something going on. We often get small bowel biopsies because the clinicians wish to exclude gluten enteropathy, celiac sprue. That's not a common disorder in a more rice-based diet, but in a Western wheat and barley and other grain-based diets, it's a fairly common thing. So they want to exclude that, and that's probably why they did this biopsy. However, as we come into higher magnification here, we can see there's a little bit of bulbing of these villi, and nothing in between the villus spaces. I always look at sure we don't have parasites or other issues. And so that's part of my systemic or my process of evaluation. I don't see abnormalities in the epithelium. And so then I start to look at the stroma. And here the stroma looks just a little bit more pink. And in fact, as we come into higher magnification, I think you can see that there is a really large number of eosinophils here. Now, eosinophils are a normal component of the lamina propria in the small bowel, but usually that number of eosinophils is, say, less than 20 eosinophils per one high power field. Whereas here, I think you could see, if you were to count them, you would be several hundred in these fields. So this is an appreciable increase. We also have a little suggestion that some of the granules are up in the epithelium. And so in this situation, we also see a little bit of glandular damage, some shrinkage here in some of these areas. And as you can see, many eosinophils here, and granules, Paneth cells being very prominent in the basal crypts. This is true in each of the fragments. And in fact, in this fragment, there's a little bit of blunting, a little bit of shortening of the villi. And in several of these fragments, we see these glands that get a little bit shrunken from this process. So I think this is a case of eosinophilic gastroenteritis. Last time we talked about eosinophilic gastritis. In this case, we're seeing an increased eosinophilic infiltrate in the small bowel. And we also, another feature here, just to note here, is notice this separation. The base of the crypts is here a few microns, maybe a millimeter or more from the muscularis mucosa, and that's not normal. So we could think about inflammatory bowel disease like Crohn's disease. And in some settings, this might be or could be a manifestation of Crohn's disease. That would be an important thing to exclude. because that can also present with a little bit of erosion, some shortening of the glands, and various variable inflammatory infiltrates, which can include eosinophils. What we don't see here for Crohn's is any fissuring ulcers. We don't see granulomas, obviously, and we don't see any active cryptitis in that sense either. So I think eosinophil gastroenteritis and or enteritis and rule out other possible causes would be the kinds of things that I would be thinking about in this situation. Obviously, ruling out parasitic disease, neoplasia, other kinds of things that can cause allergic phenomenon is important. But oftentimes this sort of eosinophilic enteritis is related to ingested allergens. So that also can be one of the differential considerations. All right, let's go on, keep on moving. We've got quite a few cases we can talk about today. Here are 3 more small bowel biopsies in this case. And here we can see there seems to be some degree of villus preservation, although they may be, again, a little bit shortened. And we see more blue cells in the lamina propria, but probably a relatively normal amount. But just notice right here along here, look at this epithelium, and you'll notice that we have some extra nuclei here. So there's at least one area here where we've got extra nuclei, and that's usually indicative of lymphocytes. Here we can see another area where we have some increased number of intraepithelial nuclei, possibly lymphocytes. So we've picked up one clue that this may be some form of lymphocytic enteritis. We'll look at a few more areas here. Here we've sort of lost the surface epithelium, and there's more blunting. And here again, here's an area right here where we have an increase in the number of extra nuclei. All these darker nuclei are probably lymphocytes. So this is the differential of lymphocytic enteritis, celiac sprue, or occasionally tropical sprue, where although the lymphocytes are not the main feature of that disorder, they can be seen in some settings. And the differential might be based on the prevalence where you're making your diagnosis, age of the patient, and so forth, and anything else you may know about the patient, such as prior surgery or things like that that might have predisposed them to one of these disorders. Now, with both celiac sprue and with tropical sprue, you tend to get a degree of crypt hyperplasia. So in other words, these crypts tend to become longer as the villi become a little bit shorter. So the purpose in showing you this slide was not so much that it is pathognomonic in and of itself, but to show you how important it is to look at the intraepithelial component and to be sensitive to this possibility of celiac sprue or increased lymphocytes. So we have a comment that we'll use in a situation like this that essentially says, mild villus blunting with increased intraepithelial lymphocytes. The differential diagnosis includes celiac disease, tropical sprue, lymphocytic enteritis. And we oftentimes will recommend that they do additional testing for, say, anti-gliadin antibodies to exclude celiac disease. Now, that testing may not be widely available in Southeast Asia. You may want to do a little bit of other clinical suggestion or investigation to see what other sorts of factors might be present. Now, if you're really uncertain as to whether or not these are lymphocytes, you can do, say, an anti-CD3 or an anti-CD45 immunohistochemical stain to assess the presence of that process. Now, if I'm correct here, I'll just take a quick look at. Yeah, so this was proven to be a case of tropical sprue. The lymphocytes are not prominent, but mild villus atrophy, a little bit of erosion, and so forth are within the spectrum of disease that you might see with tropical sprue. I don't think this is the best example of tropical sprue, but we don't always see classic histology, and so it's good to be able to recognize the features, include the differential diagnosis in our considerations. All right, well, we'll go on to the next case here. Again, we're in the small bowel, and here we can see what looks like some maybe Brunner's glands. We can see some villi here. They look relatively normal, maybe a little bit blunted and shortened. If we look here, the crypt to villus ratio is about 50-50, and it really should be maybe 1-4 or 1-5 rather than 1-1. So there's a suggestion there may be some villus blunting over here, and over here we can see even more of this characteristic loss of villus architecture. We see the surface here coming along, and crypts and so forth, muscularis mucosa down here, but very little in the way of villus architecture that's normal on this fragment. So let's see what we have here. Do we have increased lymphocytes in this sample as well? So looking at this area right here, what do you think? Do you think we've got too many lymphocytes in that epithelium? Somebody respond. I guess we could put a poll out there. I think you can see that there's just a little bit on the too many nuclei in this area. And normally the lymphocyte to enterocyte ratio should be no more than 1 lymphocyte for every 5 enterocyte nuclei. So that's a good rule of thumb. But looking around here at other areas on this sample, here again, you can see a nice area here where, you've got 1, 2, 3, 4, 5, 6 lymphocyte nuclei right there in the space of 7 or 8 enterocyte nuclei. You could do a similar count right here, maybe a similar count right here. So you've got more lymphocytes, more small black nuclei here than you should have. So in fact, this is a nice example of celiac sprue in this patient. This is not a fully developed Marsh stage 5 kind of lesion. This would be more in the Marsh grade 3 category of some villus blunting, increased lymphocytes, and so forth. In reality, we don't use the Marsh grading system from a pragmatic sense. It's mostly used in research settings, and our clinicians have not demanded that we use it. So since it's kind of a pain in the neck, we don't do it. But again, you can see there's a spectrum of disease. Some areas have relative sparing of the villi, although again, I think these are slightly shortened. And so sampling, but again, I think you can see there certainly are some areas here where you have increased numbers of lymphocytes. So this is, again, underscores the value of sampling, good sectioning, examining each of the fragments that you've got to see what clues you have, because it may not be uniformly distributed. Now, if you were to say have just a sample like this, and you saw these increased lymphocytes in the villi here, again, we would include a comment that said something to the effect that we have intact villus architecture, and we have increased intraepithelial lymphocytes. And then we would give a differential, recommend some follow-up treatment and clinical correlation. There's going to be follow-up testing, anti-gliadin and so forth, to evaluate this scenario. So I put those two cases together just so you'd have them as a nice contrast, one with the other. And of course, I'll give you the links to these slides so that you can come back and compare them. And so when you have a biopsy, sometimes it's nice to remember, oh yeah, Dr. Hassel showed us an example. Let me compare my case with that one. And you'll be able to come back and find these cases. All right, well, here's another small bowel biopsy sequence. And here you might have a little bit of difficulty recognizing this as small bowel because we have virtually no residual villi. But we do have, some enterocytes. Well, are we in small bowel? Let me just make sure. We certainly have some sort of pyloric type glands here. So we could be closer to the pylorus. And let's just see what else we've got here. So the first question I always ask is, where am I? Where did the sample come from? And this is part of the way we do that evaluation. What kind of epithelium we have and what's going on. So we don't really have much in the way of villus architecture. I don't see very much in the way of goblet cells, maybe a few suggested cells. So we might still be in the pre-pyloric area. And what we are seeing is quite a lot of lymphoplasmacytic cells in the lamina propria. Some added eosinophils here, so the inflammatory changes are certainly a little bit prominent. And then as I notice and I look at things here, I notice that we have a bit of collagenous tissue here in some of the subepithelial surface areas. And I see, maybe some degree of a little bit of loss of polarity and some changes in the surface epithelium. So I'm starting to wonder about something like collagenous gastritis or collagenous sprue, something in that category of disorders that might give us some blunting and also give us some of those inflammatory changes. Well, I'm not seeing a lot here in that regard. We have a little bit of an ulcer, an erosion. And then here again, we see a little bit more of this collagenous tissue. So I am suspect that we have some collagenous type of disorder going on, because this is not a normal amount of hyaline pink tissue in the subsurface areas. And we do have the lamina propria increase in inflammation here. So this could be pylorus with sort of the combination of collagenous gastritis, collagenous enteritis type of change, which you can see here. And there is some degree of epithelial damage, there's not much in the way of active inflammation there, but we do have that in the lamina propria here. So this might be a case where I would be a little bit descriptive, because I don't think this is a totally slam dunk diagnosis. But finding this increased collagenous tissue here is certainly quite suggestive of a collagenous inflammatory disorder that is usually associated with some sort of lymphocytic enteritis. Now, many people will do a Masson's trichrome to demonstrate that this is collagenous tissue and not fibrin. If there's a question, that certainly is a helpful and confirmatory test that can give you that bit of information as well. So I think I've gone through the spectrum. We looked at the surface, we looked at the inflammatory, the deep stuff. We haven't looked at the muscle. The muscle looks okay. Inner surface areas looks okay. This is not the pattern that we would think of with, say, Helicobacter. Helicobacter does not give you that collagenous reaction and is not associated with increased eosinophils. So we can exclude Helicobacter in this situation, but you should think about it in any sort of active gastritis. In fact, we usually make a negative comment in almost every gastric or pyloric biopsy, because if we don't, we'll oftentimes get a phone call. Did you test for Helicobacter? And we like to answer those questions before the questions arise. So, okay, so let's go on to the next case here. Small bowel, again, this is, as you can see, a little bit of a resection specimen. So we'll take a look here at what we have over here, and it looks like this looks pretty normal. Here we see a nice normal crypt to villus ratio. So it's like 1 to 5 or 6. We have plenty of goblet cells. We have some Paneth cells down here. A little bit of space between here and the muscularis mucosa. And then the submucosa is a bit inflamed and so forth. A little bit of active congestion here. But obviously, this is not why the surgery was done. The surgery was done because we have something going on over here. And as you can see here, there's some penetrating vessels. And then we have here a little bit of alteration in the muscle, a little bit of a curving here around to what looks like a little bit different type of mucosa. As you can see here, we have foveolar type epithelium, and here we have nice gastric oxyntic type glands, a mixture of chief cells and parietal cells. And so in this scenario, which was removed as a diverticulum, and is certainly forming what looks morphologically like a diverticulum, I think you've probably arrived at the diagnosis of heterotopic gastric mucosa in a diverticulum of the small bowel, or what is commonly known as a Meckel's diverticulum. Now, not all Meckel's diverticulum will have gastric mucosa. They can be composed of small bowel mucosa. These lesions occur on the anti-mesenteric side of the small bowel. So if you find them on the mesenteric side, it may be a reduplication or a different sort of anomaly, not rather than the embryologic omphalomesenteric duct remnant that usually is what gives rise to the Meckel's diverticulum. Now, a question that sometimes appears in board exams for those of you who are thinking of taking examinations is, Where in the body can you have ectopic gastric mucosa? So Meckel's diverticulum is probably one of the most frequent. There are two other upper gastrointestinal sites. One is in the esophagus, just distal to the cricoid cartilage. You can have what is often called an inlet patch of gastric oxyntic mucosa. It's usually not symptomatic, not a problem, and the endoscopists see it frequently enough that they oftentimes do not biopsy it because they recognize it for what it is. You also can see ectopic gastric mucosa in the first portion or in the duodenum, usually in the first portion. There it's sometimes a little bit more subtle and difficult to identify. That's something you need to sort of be aware of, because you may just think they biopsied the stomach and they mislabeled it. But finding it in conjunction with small bowel villi is very helpful. And then the final place, and certainly the least common location for identifying heterotopic gastric mucosa, is in the rectum. The anorectal area can occasionally be found to have an almost plaque-like area of gastric type mucosa. How it gets there, I don't know, but that's been described. I think I put a case up a year or two ago of such a situation. All right, well, let's go on to the next case. That one was pretty straightforward. This one also, again, fairly straightforward. We can see that we're here in the duodenum, because you can see here we've got some submucosal glandular tissue that probably is Brunner's glands. It doesn't look like it's pancreatic type glands, so it's Brunner's type glands. We've got villus architecture here with reasonably redundant villi. So we're in the duodenum, and we've got a resection specimen here. So it's probably on account of a neoplasm. And here we can see this has been slightly turned, but we have Brunner's glands and periampullary glands, a little bit of Brunner's gland dilatation here. And then we have this neoplastic or proliferative process here in the ampullary area. Now, it changes the nature of the secretion. Notice we had clear secretion with the Brunner's glands, but here we're seeing a bloodier fibrinoid secretion. We see a little bit of loose desmoplasia around some of these glands, raising possible consideration of invasion. And here we see some of this tissue intermixed with the Brunner's glands as well. So this looks like it's some sort of papillary adenoma, and we should then inquire as to what kind of an adenoma we're dealing with. Do we have dysplasia? So we've lost some of our enterocyte nuclei, but the nuclei look still basal, and at least in this area. Here in the center of it, we're seeing a lot of sort of sloughing cells. So there's some sort of excretory almost type of change. And then here in these areas, as you see down here, looking a little bit more disorganized architecturally. And here you can see a little bit more clearly, we've got rounding up of the nuclei. They've lost their polarity. We've got nucleoli, mitotic figures. So we have at least an adenomatous type of epithelium or a low-grade dysplasia in that focus there. Here we have more of it. And you can see it's not uniform, it's variable. not too obvious here. And then we'll look at this little fragment over here. And here again, we can see, nice hyperchromatic nuclei, slightly enlarged, a little bit pencil-shaped. So we're getting essentially a tubular adenoma type of change here with at least some focal areas of fully developed dysplasia and a suggestion that we've got some degree of reactive stromal changes. So in fact, tubular adenomas of the ampulla are one of the lesions, neoplasms that we see fairly frequently. Particularly the patients who are prone to this are those who have some sort of genetic defect in the APC gene, such as might be found with familial polyposis. But they can also develop spontaneously and sporadically in patients without known genetic alterations. Now, in fact, as we come here to the surface in some areas, we'll see that here also we probably have some of this dysplasia because we've got mitotic activity, we've got hyperchromasia, a little bit of stratification here. This is not always an easy diagnosis to make. And so I think looking at the different areas of this, understanding what we saw deep down and seeing, this sort of a pattern, this sort of proliferation, these long villous fronds here, and these central sort of rounded up areas, atypia, macronucleoli, should give us the kinds of courage when we just see a piece of this to at least suggest the possibility that this is a tubular adenoma, possibly could be related to potentially even invasive carcinoma in this situation. Now, this patient should do very, very well. This was confined to the ampulla, not invading the duodenal wall. And so assuming they survive the surgery, they should do very well. Okay, we'll go on. Next case. So as you look at this case, you can see we have muscular wall and a mucosa here. But one thing I notice here right off the bat is that this is a small tubular structure. So this looks more like an appendix. But in fact, this was from the small bowel. As you can see here, we have villi. And so that alone should probably tell us that we're dealing with an infant or a child, potentially even a newborn, to have this size caliber of the small bowel. And in fact, in this particular sample right here, I think you can see that we have areas of fibrin and mucin extrusion, damaged glands. We have a little bit of hemosiderin in the wall where we have no surface epithelium. So there's been some bleeding or other damage here. And we can see here's some fibrin clot on this surface of the lumen there. And then over here, whoops, sorry, we see features that say that's going on even further. And we have mucin, hemorrhage, and macrophages here in this process, along with damaged sloughed epithelium. So in the newborn or a young child patient with an ulcerating or necrotizing process, this is different from what we would see in an adult, where you might think about, an ischemic ulcer or something like that. This is almost certainly necrotizing enterocolitis of the newborn with an apparent area of perforation with this mucus and inflammatory cells leading to damage to the wall as you can see there. So that in fact is the diagnosis here, necrotizing enterocolitis. In I think the child was a month or so old. And just highlights the fact that small bowel disease is not necessarily a disease of old age. There can be newborn processes or young children who have serious GI disorders, and this was I thought a nice illustration of one of those, which I don't see this very often because I don't deal with pediatric patients generally, but found this in the teaching files and thought it would be a good example to share for your reference. Okay, so let's go on to a little bit of neoplastic disease. Again, we see a resection sample, small bowel mucosa over here, attenuated villi and so forth, and then this very sclerotic pattern lesion extending into and through the wall, as you can see here. So the other feature that I think you can begin to pick up at low magnification are these little punctate areas here. As you can see them here, we'll see what they are as we go to higher magnification, but those are things that should get some attention. We got a few more down here as well. So we'll go down here, and not surprisingly, this sort of a pattern, sort of insular and cribriform, glandular, pseudoglandular pattern is with fairly uniform nuclei, abundant pink cytoplasm, highly suggestive of a neuroendocrine tumor. You can see, I think, some characteristic nuclear features, round nuclei, slightly clock-faced a little bit, but sort of granular, finely stippled chromatin. The term that we use in the oftentimes in the United States is salt and pepper-like. Some pale white areas, some darker areas. So that certainly applies here. Now, what were those stippled areas? Well, here's one here. And I think you can see it's a little maybe calcification there. We'll look for a few more here and focus in on those. So here's another one up here. Sort of a little hyaline rim of darker blue with a central paler area, a little bit of lamination to them. These look pretty good for Samoma bodies. And I'll look at a few more just so that you can be convinced. So here's a few more. Again, they don't often section very well. Here's a couple that are nicely sectioned here in these lumina, and a few more over here. So I think you can satisfy yourself that we do have a fairly abundant Samoma bodies in this lesion. So those two patterns, the sort of tubular and insular pseudoglandular pattern with associated Samoma bodies in the duodenum. This is fairly characteristic of a neuroendocrine tumor with a specific hormonal phenotype, and that is the somatostatinoma, somatostatin producing tumor. And that's not necessarily prognostically important per se, aside from the fact that these are rarely, if ever, malignant, rarely metastasize, and certainly may be associated with a secretory component that includes somatostatin. So recognizing that and being aware of that lesion, which is relatively specific to the first and second portions of the duodenum, I think you'll be able to impress your clinical colleagues when you make the diagnosis, and even without looking at any of the biochemistry, suggest the possibility that the patient has a somatostatin-producing neoplasm. So those were the teaching points for that case. I'll go on to our next case. Oh, here's a related slide. Different portion of this tumor, an immunohistochemical stain for somatostatin. And as you can see, you have nice positive granular sort of cytoplasmic staining in many of these cells. And notice the sort of dot-like or granular pattern to the staining pattern in this tumor. Okay, now we'll go on to the next case. Back to the small ones. Okay, so 3 or 4 small fragments. We'll look at these representative samples here. And you'll probably recognize this low magnification as we get into here. Well, we have some sort of clear spaces here. These are artifacts related to the procedure. So this is a endoscopic procedure where the endoscopist has injected air into projected some air to try to inflate the bowel. And in doing so, they've injected air into the mucosa. But aside from that, I think we can see here there is maybe a suggestion of some sort of a pallor type of infiltrate in these villi, some of them slightly enlarged. And here's another one, as you can see, some sort of pale bluish gray, pinkish gray cytoplasm to these cells. They don't look like normal lamina propria cells. And even some of them down here in the deeper areas of the mucosa with this slightly pale bluish gray cytoplasm. So this raises the differential of what can give us this sort of an infiltrative process. These don't look atypical. They don't look neoplastic. The nuclei are quite bland. So what can give us an infiltrative process that includes these sort of histiocytoid cells? Well, it could be a signet ring cell carcinoma. That's certainly a possibility. It doesn't particularly have an infiltrative pattern, although here we do see some in the submucosa as well. And here, it's not a signet ring pattern. The nuclei are not particularly atypical or pleomorphic. So I think it's unlikely that this is a neoplastic process, although in the truest sense, many times these cells actually can spread to other organs of the body, including brain, spinal cord, and so forth. And in doing so, they oftentimes will carry with them what they contain. And the way to demonstrate what they contain in this situation is to do a PAS stain to demonstrate that these cells contain I thought I had an annotation here. Let's go to one of these annotations. Yeah, so here's a nice example of them. To demonstrate that these, the cytoplasm of these cells contain abundant PAS positive small rod-shaped organisms. So this is an example of Whipple's disease or Triphanema whippleyi infestation that produces this congruent congeries of microorganisms that are engulfed within these macrophages, and which, as I noted, can spread and create the possibility of seemingly metastatic or systemic disease that originates here in the small bowel. So we don't see this very often, and I thought it would be nice for you to have the experience of seeing how subtle this can be in this situation to identify these small clusters. Because usually we think of histiocytes as being sort of larger, foamier appearing cytoplasm. These have this more bluish gray coloration, which is more challenging to identify. All right, we're moving right through these. We'll go on to another case. And this is a case that is not really a diagnostic problem, but is uncommon in our setting. And I don't know if in your settings this is more commonly seen. But as you can see at low magnification, in each of these glands and with some of the epithelial spaces, there are these clear spaces with central dark structures, and they're sort of conjuring around the crypts. Notice here that we get quite a degree of crypt hyperplasia, and we do seem to have some loss of villi. So there is evidence that the mucosa is damaged. As you come into higher magnification, I think you can appreciate that these are non-human structures. They're non-bacterial. These are, in fact, small roundworms, strongyloides, probably larval forms in this size. But sometimes you can have larger full-size worms as well in this location. So it's nice to identify these before you give the patient anything that might be immunosuppressive, so that they don't develop a dramatically invasive process, as these worms can respond to steroids and other drugs like that in a rather unpredictable way. So a nice, fortunately uncommon example of strongyloides stercoralis enteropathy. And you can see kind of the secondary changes that are evoked here. We have a little bit of eosinophilia, not as much as we saw earlier in the eosinophilic enteritis. We have some epithelial damage, a little bit of chronic inflammation, and as we noted, the crypt hyperplasia. So in small samples, you may only get a little fragment like this or this to be able to suggest the possibility, and so be aware to look for those sorts of things within the lumen of the bowel or within the lumen of the glands as a possibility. All righty, here we go. One more case here, or maybe we've got a couple more. Here's a nice case that looks abnormal at low power. It's all blue. We don't see any evidence of villi. We've just got blue tumor tissue. And I put this case in because I'm going to use these slides with my first and second year residents tomorrow. And I wanted them to see what a starry sky pattern looks like. This is certainly textbook quality for what a starry sky is supposed to describe. A lot of blue cells and these clear spaces with karyorectic debris within macrophages. Now, as you can see here, the starry sky, the sky portion, the blue background, is in fact these high-grade nuclei with tons of mitotic figures. Probably you'd have 90+% labeling with Ki67, because these are all blastic type of cells. And this is, in fact, an example of lymphoblastic lymphoma, Burkitt's type lymphoma, which involves the small bowel. And the terminal ileum, colon, is a fairly classic site for involvement by Burkitt's lymphoma. Usually we don't get this generous a biopsy. These days it may be more likely a needle biopsy or much smaller biopsies. But this has such wonderful morphology, showing you nicely the very high grade appearing lymphocytes, lymphoblasts, and this very classic lymphoblast, or the starry sky clear cell areas with karyorectic debris and so forth. All right, well, we'll see what else we've got here. I think I have one or two more. So this patient has, I think this is actually maybe a little bit more towards the colon, maybe the terminal ileum and colon area. We have a very mucinous type of epithelium. We don't have much in the lamina propria here. And then we have this gap that looks kind of eroded. And then some regenerative changes here, maybe pseudovilli forming up here and so forth. So let's see what's causing this ulceration here. And take a look and see what's going on in the epithelium. Now, I think oftentimes the juncture between the erosion and the normal tissue is the very richest area for identifying the processes that may be going on. And so looking here, I think we can see a couple of things. So this pattern here, where we have kind of apoptosis going on, and a few bits of nuclear debris sitting around. I think this is what I like to term an apoptotic pattern, where you've got individual cell death and damage that's going on. And I think one of the things in our setting that I always have to think about in that circumstance is some sort of graft versus host disease as a possibility. Is it some other sort of anti-self attack that's going on, or some other immunologic process that's going on that's causing that as well? I don't see too much of that as we go a little bit further over, although here's some apoptotic debris here, and there may be a little bit more. So I don't see the popcorn cells. Maybe there's one up here. Well, a few rare intraepithelial lymphocytes that sort of look cleared out. So it would be, this would be only be graft versus host disease in the appropriate setting of someone who was some period of time out from transplant. I always look for secondary causes in a situation like this. And in fact, the most frequent secondary cause that I would consider is cytomegalovirus. And if you'll notice here, we have sort of an eccentric nucleus with a somewhat prominent nucleolus and a little bit of pale pink cytoplasm that could be a CMV infected cell. We can look a little further in this ulcer and the areas around it here. Here's a few more possible cells. And the cells that can be infected with CMV include endothelial cells, epithelial cells, and sometimes just the stromal cells. So you do have to look fairly carefully at all of these sorts of areas. Here's some more sort of smudgy, altered cells here that raise that as a possibility. Again, another cell over here. So there's a fair number of these sort of smudgy, atypical cells. And here's another one up here in the corner. So I think CMV enteritis, possibly in the setting of graft versus host disease, is what I would consider here. Here's a little bit more of this sort of intraepithelial lymphocytes with a bit of apoptosis here. Again, raising the possibility of graft versus host disease with secondary or associated CMV, enteritis, and ulceration. Now, notice that this ulcer is really very clean. It's very dry. There's not a lot of pus or fibrin or inflammatory cells. And that's fairly characteristic of CMV, that you get that kind of process. But it's also characteristic of patients who are immunocompromised or immunosuppressed. So I know you don't see a lot of these kind of immunosuppressed opportunistic infections in Southeast Asia to the same degree that we do, but I'm sure that over time that this will become more prevalent as you become more adept and treat patients closer to death's door with various anti-neoplastics and other therapies. Okay, one last case here. And this is, again, for illustration and future knowledge. This is not a common situation, but I think illustrates a couple of the points. You can see here we have some villus blunting and a little bit of bulbous nature to the villi in this sample. Here you see a little bit of vascular ectasia, and again, this sort of fibrinoid change in the surface. And then notice over here, we have a few glands with increased mucin and some alteration to the mucin content of these cells. Looking a little bit more closely here, you'll see we have fibrin deposition here in this, and this is stained a little bit more brightly pink than might be optimal. And related to that, we have a little bit of ischemic change, some hemorrhage associated with this change, a little bit of early sloughing of the surface epithelium. There's nothing specific here. There's just this evidence of fibrinoid hemorrhage, a little bit of villus blunting, not really any specific inflammatory changes. And then we have that epithelial change with increased mucin in a few glands. So this is I guess you'd say a complication of checkpoint inhibitor therapy as manifested in the small bowel. And what I've learned, or I'm learning about checkpoint inhibitor enteritis, is that it can take a variety of forms. It can look like lymphocytic enteritis. It can look like microscopic colitis. It can look like inflammatory bowel disease, and a variety of other things. So a non-specific case like this, be sure to check the history to see if there's something funny that you might need to know about. And in that circumstance, point out the possibility that these changes are associated with that. Now, I mentioned these dilated glands here because there are certain types of chemotherapy inhibitors and so forth that can inhibit the normal maturation of the enterocytes and can lead to dilated glands with an increased mucin content. And that includes a number of the Notch inhibitors and a few other things like that. But it's a very non-specific finding, of course. But in the setting of someone who's getting that therapy and has other sort of low-grade, non-specific findings, I think you can attribute it to that sort of a change. Well, we've come up to the end of the hour, and I think we'll stop here, and I'll take any questions that anyone has. You've all been very, very quiet and patient in listening to me, and I hope have understood as much as you can. What questions do you have?
Thank you, Professor. There are a lot of interesting case, and in my hospital, I see the whipper in the small bowel and strongly loitis in a small bowel. Look like the same case, same lot. Thank you.
Yeah, that may be more common there, but it's good for our residents here to also see it and be reminded of that as well.
I can ask you a question. When the Whipple case, histoside maybe stand with the PAS, or why? I don't know.
So yeah, that's a good question. Why do the Whipple's organisms stain with PAS? They do stain with other stains, but I think PAS usually is helpful for polysaccharide rich structures, and the bacterial cell wall seems to have a rich array of polysaccharides. Now, there are other stains that will identify them as well, but they're not quite as specific in that location. There is also an immunohistochemical stain that can be very specific, but it's only one or two places I know have that on their menu of stains. So PAS is something that's usually commonly available and can be done in a wide variety of settings.
Thank you.
Anyone else have questions?
I don't have a question, but I'm not expert in with the interpretation of a small intestine biopsy, but we receive some case like patient just come for diarrhea or some other symptom like a minimal GI symptom. So when they do endoscopy, they said it is normal, and they ask a question, can be this or that, and it's hard for me, just we try to say something specific, but when there is only inflammatory or maybe some case like you have show us celiac disease, it's hard to say. So I don't know how to give a conclusion for some kind of this kind of interpretation. How can you recommend us?
Yeah, so I think one of the most common diagnoses I give in the small bowel is architecturally intact small bowel mucosa. And that means I don't see evidence of sprue, because they're asking, is this sprue? But you do have to look for things like Whipple's. You do have to look for organisms, Giardia, Strongyloid, these other parasites that can be present. And the inflammatory changes in the small bowel, I think, are very hard. And that's why we started out with that eosinophilic case. But it almost has to be that extreme before you can say there's increased inflammation, because usually the small bowel is very immunologically active. There's a lot of lymphocytes, plasma cells, and eosinophils in the lamina propria in the normal biopsy. So I don't say non-specific chronic inflammation or things like that. I just say architecture is intact, and I don't see any pathologic process in that circumstance. And that's okay, because most of the time patients have symptoms. It's due to something else. It's not the small bowel that's responsible. But I feel for the dilemma you have. Anyone else have any questions?
Oh, thank you, Professor.
All right. Well, I certainly wish all of you in Vietnam who are having a holiday, a very good holiday this weekend. We have a holiday also, and we will enjoy it. And we'll look forward to talking with you next month.
Yes, thank you.